So the reason that we do this is that it really works okay to track pain intensity scores in an acute post-op, post-injury setting. Chronic pain management is much more complex than that, and you can't just track pain scores. We actually have an article coming out about this next week in the New England Journal about why pain scores don't work in chronic pain. So next Wednesday, that'll be available through the New England Journal. So we feel like you got to go beyond pain intensity and see how the patient is doing with their, not only their pain, but their function, mood, sleep, and satisfaction. We can't just look at them once. We can't expect there to be a cure. We have to look at how these different outcomes improve or deteriorate in response to treatments over time. And it's only the total picture that really is informative. It also helps to engage patients in the effort to improve their lives by giving a more complete picture. Turns out that any assessment tool is also a teaching tool, and all of a sudden patients see that you're attending to more than their pain scores. They become interested in more than their pain scores as well. So this is the basic pain tracker that we work with on TelePain with pain locations and a set of outcomes all scored from 0 to 10. Right there we have the pain rating and then the general activity and the enjoyment of life. Those first three are the PEG. Falling asleep and staying asleep are next. The personal activity is introduced there with that short paragraph, and then the difficulty is again ranked 0 to 10. The PHQ-4 is one of the few items that we actually have that doesn't have a 0 to 10 rating, since those response options are preset in the instrument itself. Side effect, bad days. We've kind of removed the bad days piece, but we want to track how often the patient is taking more than prescribed of their pain medication, particularly if they're opioids, and have found that to be a useful initial screen for people who might be getting into trouble with their opioids or misusing them. So the output of the basic pain tracker consists of these three graphs looking at general pain interference, and then in the red, and then the interference with their own personally selected activity in the blue. We track pain intensity and emotional distress. Pain intensity is that 0 to 10 score. The distress is the sum of the PHQ-4. And we watch how those track together. They often do quite closely. And then sleep interference, both falling asleep and staying asleep. The reason we track these separately are because sedating medications, your Ambiens, your Z-drugs, may help with falling asleep. They don't help with staying asleep. You have to often go to something like an antidepressant or a tricyclic to help with that. So they tend to be independent dimensions. We track the pain sites, morphine equivalents per day, color-coded according to state guidelines. The number of days they exceed per month are all down in that pain table, as well as other non-med opioid meds that they take, treatment satisfaction, and their important activity. So this is what the patients will see on our web-based version. The paper version looks similar, as I showed you just a little while ago. We use a somewhat more extensive version here in our Center for Pain Relief. It's a tertiary care referral pain center. We do a number of screening tests that we just administer on the first visit. They don't get them every week because there's not a lot of change from week to week. Looking at opioid risk up there in the top left-hand corner. The Audit C assesses for heavy drinking, PHQ-9. The suicide item is pulled out. We track PTSD symptoms with the simple PC PTSD screener, simple 4-item screener validated by the Center for Traumatic Stress, very useful. We track also sleep apnea risk with the STOP tool. We have very high rates, as I'm sure you do, of sleep apnea related to our high rates of opioid treatment. And for people who are on opioids, we also track what problems they're reporting with them, what concerns they have about addiction, etc., that they might be having about their opioids, whether they consider their opioids helpful for pain, and whether they're interested in tapering or stopping their opioids, since those items really help open up our opioid conversation. Do people want to explore other treatments? We do display the areas that are hurting, as well as now a bit more extensive list of pain outcomes. We've got intensity and interference on the top scale, depression and anxiety, a little more extensive, PHQ-9 and GAD-7 in the second graph, sleep initiation and maintenance in the third, and then we have the important activity and a more extensive functional measure, the Oswestry Disability Index, graphed in the bottom there. Since we are also treating patients with interventions and procedures, we have a way to mark those on these graphs. If you note up in those top few lines, we've got a dotted line for if they received an injection, kind of a dotted and dashed line for when they started physical therapy, and then a solid line for when they began behavioral therapy, working with a psychotherapist, etc. Just so you can see if those treatments are associated with inflection points on the PainTracker graphs. Our report goes off into a second page where we look at some more longer-term metrics like quality of life and satisfaction, as well as some of those items that were in the table before, like days of excess meds and important activity. We also use this second page to give some item-level detail if you want to drill down and see which items people are endorsing over time, so you can target your treatments. They're printed out right here. So one important thing to remember about pain care is that the very most important outcomes are those that are reported and experienced by the patients. We may like to look at the lumbar MRI. We may really find it helpful to look at an EMG or certainly a physical exam, but it's the patients that are going to tell us whether they're doing better. And we need a multidimensional look at this. We need a longitudinal look at this. And we need to be able to talk about this whole picture with the patient, because they're going to understand the way that we're thinking and the way that we're working for this. We do also have another version that we've developed for our sports medicine clinic. So they're a little different patient population. They have more focal problems. They're more acute. They need some more detail on physical location and specific joint-specific problems, and a little less detail on some of the psychosocial factors. But it allows a kind of system-wide patient-centric tracking as well. The action tracker looks like this. It's a little bit small for you to be able to see everything. One nice feature is that as you click on body parts, it will key up particular assessment instruments, the NDI, the FADI, basic on ankle, the simple shoulder test, etc., for other body areas, so you can track in detail how people are doing on a particular joint. Again, it really improves clinical process in the same way that the PainTracker does. It saves time, directs the visit, improves outcomes, and allows reporting on these metrics by provider or by the clinic. So this is the PainTracker picture again. So we've worked a version into the Cerner EMR, and we are in fact currently beta testing this. We are working on getting into the Epic and other EMRs. We're deploying into a whole bunch of different clinics and interested in generally in dissemination. And then this is the REMS program on safe opioid prescribing that's helping support the program, which you can access at coperems.org.